Okay, let's go. We are online now.
Hello, everyone, and welcome to PAVSS webinars. I'm Dr. Habballah. I'm the president of the Pan-Arab Vascular Surgical Society. I'm delighted to be moderating this webinar session today. As you know, we have been doing webinars alternating with journal clubs, and this is our second webinar of the year. I am delighted that we have with me today co-moderating this webinar and serving as a panelist, Professor Rafat Jaber from California, Professor Melhem Sharafuddin from Colorado, and sitting nearby with me here is Professor Ma'moon Bashir from Jordan. This is a special webinar today because our guest speaker is Professor Carlos Bechara. Professor Carlos Bechara is a board-certified vascular surgeon. He's the chief and program director at Rush University Medical Center. He received his general surgery training at Tulane University and has completed his vascular fellowship at Baylor Medical College. He's a internationally known expert in aortic surgery and in especially complex endovascular treatment. He has written more than 100 publications and co-edited a vascular surgery textbook, Anatomy, Exposures, and Vascular Reconstructions. And we are delighted that he's with us today to talk about physician-modified endografts, tips and tricks based on his experience with more than 200 cases. And our panelists, Dr. Melhem Sharafuddin, Professor Melhem Sharafuddin, and Professor Rafat Jaber have also been very experienced with that field. So we will be having hopefully a very nice discussion on the topic. So without any further ado, Professor Carlos, the floor is yours. Welcome.
Thank you, Dr. Habballah, for the introduction and to be part of PAVSS webinar. It's an amazing society, and thank you for your leadership, and I thank the committee for the invitation. So this is my disclosure. So this is the outline. I know the title is mainly focused on tips and tricks, but also part of the tips and tricks, I think you really need to build a program and I think seal fixation, troubleshooting, access and angulation, and spinal cord ischemia, as well as costs to lead to a very successful and durable repair. I think it's the most important thing. And now, luckily, since I've been doing this for a long time, I've seen a lot of patients who had long and lasting durable repair because of this thoughtful process. So I'm going to take you through how to, before we do the graft, where do we start? So I like TeraRecon. There's other central line softwares. I really like it. As you can see, I typically, if both sides are equal, I like to go with the fenestrated or the branch device from the left side, because this way I could work from below. I typically try to do everything from femoral approach. Occasionally I come from the arm. Once you get the central line performed based on what you think the wire is going to be, then you would perform your central line. You can get diameters. And then from there, you go to the complex area where you basically size everything. So here, the PE means where the proximal edge of the stent is going to be. And then that depends on several reasons. Like if I don't, usually like in this case, it's 36 millimeter. My go-to is 3.5 to 5 centimeters. And to have like a durable seal in this area. And then you can see the MCA, which is celiac, SMA, renals, and you measure the distances. And then here to the bottom left, this is called the clock position, where you actually measure the clock position of each target vessel. Once you gather all this information, then you can put it in this table. Like for example, here you can see the celiac artery is at 1230, the renal is 245, and the other right renal is 935, and that gives me what we call the arc length. So I have all that stuff with some drawings on a book that I have, which I should have taken a picture of it, and which I take with me to the operating room. And then this is the end product. So I'm going to a little bit talk to you about this. So this is an alpha device.
R1.
you have to remove the, there's two ways you can resheath this device. You can completely deploy it and resheath it from the back using peel-away sheath. Or what I started doing recently is remove the barbs here, and then basically perform the fenestrations. And then I used to do a posterior constraining wire, but now as you can see, I put chromic circumferentially, and I like it because this really constrain it 360 degrees. So if I need to move the device, all the fenestrations are moving in the same anatomic position. So I moved to this, and then this technique, and the chromics, when you balloon it, they just pop and they open. Finally, I want to point out, you can see the tip of the graft is cinched more than the others, and that saves me a step because when you're working with big aneurysms and you try to cannulate the device, you want to make sure you're in the device before you start with the fenestrations. And then by doing this, then your wire or your catheter can loop easily in that narrow area. This way, I confirm that I'm in the device to save me some time so I can move along with those cases. Once you have the device like this, then you resheath it. So you cinch down the device with silk and ramels, so you can really cinch it down. I used to tie the silks, and now I do this. It's easier to remove, and you can basically resheath it from the back, no problem, and device is flushed and ready to go. So people ask me, where do I start? This is how I started. This was my first case, was an iliac branch device modification, homemade or my own iliac branch device. And the reason for that, if I mess it up, I can get away with it. I just cover the hypo and deal with it later. But that's how I started. Then I moved on maybe to 1 fenestration, 2 fenestrations. So I started slowly to build some experience. And then I moved on to more complex cases. And then this case actually showed up in Houston when I was at the VA. Was a contained rupture aneurysm in a patient who had previous open repair. And luckily, he was stable. That allowed us to build 2 fenestrations. He lost his right kidney from at the time of the rupture 10, 15 years ago. And we published this in JAMA Surgery with this technique. Now, this is a TX2 device, which was my favorite device to modify because of the thick tacron, and they allow me also for the easily to put the posterior constraining wire. And then you can see here, that's a posterior constraining wire. So basically what we're doing here is we're looping from the back, the 2, as you can see here, we're looping the stents through the constraining wire. So when you pull the wire, those sutures get released, and then the stent open up. And then one thing I want to point out in this case, this was one of my first cases, you can see published in 2014. I used to pre-cannulate the SMA on my target vessels, or at least the SMA and 1 renal artery to be safe. I was worried, what if I don't get in? What would happen? So I used to pre-cannulate them as a safety. But honestly, I don't do that anymore. Now that I gained a lot of experience, and now that we have other tools to get into those fenestrations, I don't pre-cannulate anymore. And also now I really trust my build after the experience with, especially after I mastered Recon. I'm very happy when I build the graft that it's gonna be aligned when I put it in. So talking about the changes in this, I remember the days when I used to do this with Vinci catheters. It was painful, it was brutal, it took a lot of time, it took a lot of innovation. But allowed us to really think of a lot of things outside the box to get into the fenestrations, as in this technique where you basically get into the fenestration, loop the wire, and then try to get into the, kind of use the sac as a backboard to get into the target vessels. But now with steerable sheath, I tell my trainees and my junior partner who do these cases with me, it's a game changer. I mean, those steerable sheath have completely changed the game, and that's why I don't pre-cannulate anymore. Like in that case, if I have misalignment, I literally put my steerable sheath through the fenestration, take a picture, point it down, and get into the target vessel if we have to. So definitely change how things we do. I think those cases, I personally, since I've done few with C-arm and few in a hybrid room with fusion, I think that's the way to go, where you mark your target vessels. And we really got so good at it that we actually start to deploy the stent even without the initial angiogram, because we were so confident with our fusion that our markers will just deploy the device and just do a completion angiogram. And we actually published our experience in JVS in 2018. showing that having this technology reduces radiation and contrast use. And I believe this article made it to the SVS aneurysm guideline, actually, showing the importance of fusion. Real quick, I used to do a lot of snorkel. I'm not totally opposed for doing snorkels and chimney, but I mean, if you look at the PMAG here in this picture, you can see how we're well opposed, a beautiful reconstruction. You know, I used to worry about the gutter leaks, and then treating gutter leaks is so painful. It's so hard to get into it. And so I completely shifted away from snorkels. I can't remember the last time I did it. So moving on to angulation, it's a problem, especially for regular EVARs, but also it could be a very big problem for some of the cases we do. This is a case some of you might recognize as stent graft. It's an anerex, which is known to slip and be in the sac, but allows me to have some room to work. But you can see this terrible angulation. So for those cases, I try to avoid, if I can, to put my device in the angulation because that really does not allow me to maneuver the device if I have misalignment where I try to rotate the device. So having physician modified allows me to put the device just at the edge where I want it with just a bare metal sticking outside. And then as you can see here, we were able to complete the repair and then basically choose where I want to put the proximal edge of the graft where I want, and then fix this this aneurysm. What about access? You know, again, you can be very creative with access. I personally, when I cannulate the target vessels, the one vessel that I always like to put the sheath and the stent in is the SMA. All the other vessels, I'm happy to just pre-cannulate with wires, but that means you need at least a 16-18 French sheath to do that. So like in this case, this was one of the very first cases I did when I moved to Chicago. This lady was sent to me for a big cardiovascular group, very frail for open repair. Luckily, it was just 2 fenestrations, but if you look at those access, I mean, they're terrible. Not sure if the numbers are showing, barely 5 millimeter on each side, iliacs. But luckily, I was able to do this repair with a device with the alpha, which is 16 French, and then only put 12 French on the other side. And despite 12 French, I actually dissected that iliac and had to fix it with a self-expanding bare metal stent. But we were able to complete the repair. And actually, I just saw her before I left Loyola for 7-year follow-up, and she has done really, really well with regression of her aneurysm sac. So what about spinal cord ischemia? Again, you know, this is a devastating complications for those who see this complication. I don't wish it on anyone. That's why I tell the patients when I discuss those complex repair. So as I said earlier, I like to put my proximal edge of the fabric within 5 centimeters if I can. I think if you go above 5 centimeters, then in the risk of paraplegia, it goes from less than 1% to, I think, 1 to 2%. Obviously, the higher you go. But also, personally, I like to keep at least 2 stents or 3.5 centimeter of distance here, because as we know, patients that have aneurysms, abdominal, they might have thoracic. And now this allows me in the future just to deploy stent really above the, in that landing zone. I don't have to worry about creating a landing zone. So I think failing forward and thinking that way, yeah, because I've seen a lot of PMAX where they done only scallop for the celiac, and those are really hard to fix when there's a proximal aneurysm. Well, not hard, but makes it more difficult to fix. The other thing I want to point here is that, again, the beauty of physician modified is you can see those intercostal 1, 2, 3, 4. I can see where I put the graft. I literally within millimeters of that intercostal to try to preserve as many and avoid paraplegia. And finally, for those who want to do these cases, I really recommend having a system protocol. When I first came to Loyola, it was 3-4 different services putting them on. I teamed up with Dr. Prabhu, one of the authors. As you can see, we published our protocol, and he's a neurosurgeon. I like neurosurgery because not only they're capable of putting in, but they troubleshoot any complications post-op, hematomas, leaks, everything. And then it worked out really well, and we got 2 publications out of it with this team. So I'm going to show you some cases and talk about some troubleshooting. I'm going to start going from like relatively straightforward to very complex cases like failed Z-fans and PMAGs and snorkels. So this is a patient that actually underwent at Cook County ruptured aneurysm 15 years ago, now more than that. And he had a cabbage, AVR, and has pulmonary hypertension. In addition to proximal degeneration, he has, I think, maybe fabric defect in the background, that he has this large abdominal sac. I mean, I don't see contrast in it, but also you can see the visceral segment degenerated. Now, I don't have enough purchase in the main body of the ABF. So in this case, I decided to modify a flex device, a bifurcated device. What really helped me is occasionally I do 3D printing because when I looked at it initially, like I said, I was going to come from the left side with the device. But when I looked at how the stent graft is going to lay with the fenestrations, I actually switched based on this 3D print, and I put the main device up the right side, and that actually made my cannulations better coming from the left side, because then I was able to open the gate in an open space, get into the gate to do my selection of the fenestrated. But what I want to show you here is that I couldn't get in well, I was able to get into the left renal, but nothing would track. Like the stent would not track. At some point, after a certain amount of time and the radiation and leg ischemia, you have to stop. And that's what I did. I actually aborted leaving the left kidney unstented. And you can see there is an endo leak there, but that's okay. And then I brought the patient back 6 or 8 weeks later. And then I brought the 014 platform system, the LD Express 014 system. Actually here you can see endo trash. The VBX actually pulled off when I tried to deploy it because I didn't have great purchase and it's sitting in the sac, but that's okay. But after I was able to get the Express stent 014 platform, then I switched to 035, and then I deployed the covered balloon expandable stent and revascularized and sealed the aneurysm. What about cost? I mean, those cases are very, very costly. So I have now a system where we try to minimize usage and cost. But I think the big thing is you want to reduce complications, right? Like we talked, whether it's spinal cord ischemia, I can IV. Now I do them all percutaneous if I can. No ICU stay. We actually put some on the floor if it was straightforward repair. Try to make the hospital happy so they can collect more DRGs. Minimize blood loss, and like I said, to avoid complications. How do you avoid complications? I think it's a must to do a cone beam CT at the end. Like in this case, there was an endo leak from the renal fenestration. We identified in the cone beam CT. We did not see it at all in the completion angiogram. And then when we selected the renal, we saw it, and then we ballooned it, and we saved that endo leak and that potential complications. So endo leak, that's something you can salvage, but obviously if you miss a dissection, especially in the SMA, that could be life-threatening and lead to patient mortality. The other thing, what I like about the cone beam CT, it's only 75 cc's of contrast. I have a protocol that I could share with you if you want, but it's less radiation. Then if I'm happy with the result, I even omit CAT scans for the first and 6 months and just get visceral duplex and the plain CT if I'm happy with my result. Finally, one thing, those cases from the multi-puncture in the sheath, we used to lose a lot of blood, and then we came up with this technique, and we just published it in JVS Cases and Innovation, where this is made by 3M. It's an IO-band basically with a sac. And the key here is you want to tape the IO-band just above the groin, so you have the big pocket where you can see in the pictures on the right where the sheath and the catheters are all within your pocket, so that when you drip blood, everything is being collected. And you can see this is the cell saver. Then we aspirate the blood, and then this has tremendously reduced the amount of transfusion in these cases for these patients. It's a very useful technique. Also avoiding pelvic ischemia. If you have a long case, and sometimes I do a cut down for those cases for that purpose, if I know I'm going to be there for a long time. And here, there's a lot of things going on, but also I do them under neuromonitoring, MEPs and SSEPs, and if there's bilateral extremity change, I do integrate or pelvic sheath here, and then in this case, actually the sheath in the SMA, also I'm perfusing the SMA because the patient has stenosis in it. Then what I do is I ask the perfusionist to give me a male-to-male connector, and then I connect the sheath from the main sheath, the 24 or 22 sheath, to the 6 French sheath in the groin and the SMA sheath. And now, as you can see, there's blood flowing into the SMA. And actually, what's nice about this, once I do the pelvic perfusion, the SSEPs and the MEPs normalized. So that allowed me to take my time to finish the case. Once you get comfortable, you can be creative. Here on the left, you can see I have 5 fenestrations. Here I had a patient with aorta uni with proximal degeneration. We pre-cannulated the target vessels from the arm. Now, for those who want to do this, one thing I advise you is to use a device like this, which does not have a suprarenal metal, especially the alpha, because then you won't be able to put your wires, and then when you open up the device, you might trap your wires. So make sure you choose a device that has no suprarenal metal. And I'll show you a picture from my good friend Sukohan, how he does it. Because I didn't save a video, but you can see you can bury the end of the wire after you snare them from the arm. You can really bury them down here in the device, and that gives you some railway to really come from the arm into each target vessel selected and stented. Then you can also you can be more creative. You can do 2 branches and 2 or 3 fenestrations. You can build an inner branch, as you can see in here, and I'll show some cases when we did that. This is the aorta uni that came in ruptured, that we went from the arm, and patient already had the fem-fem. And actually, I stuck the fem-fem and perfused the other leg while we're doing this procedure. This is a failed snorkel case. As you can see, the snorkel on top is floating. I actually have a similar case I'm going to do in 2 weeks here with failed snorkel. And actually, it's a combination of snorkel and CFAN failure. It's going to be a tough case, but this is what you do. You pass your catheter through. As you can see, no suprarenal metal. You feed your wire, and then once the wire comes out, you can feed it in the device. And then, like I said, and then you snare it from the arm, and that allows you to do what we call sequential deployment. You deploy the first fenestration, you get into the celiac, you stent it, and then you just basically keep doing sequential deployment and stenting and angioplasty. So this is actually a patient that I treated, had a ZFAN that presented to an outside hospital with abdominal pain. Sick patient, 86, CKD3, AFib, and newly diagnosed lung cancer. Actually, he was supposed to get chemotherapy, but then came to the emergency room with abdominal pain and rupture. I was able to obtain from the company what size fever they did. That's very helpful to call the cook company. And then I want to know the fenestrations, the distances, the clock positions, what they did, what size stents, so I can have a successful repair. And as you can see here, let me play this one too, is the renals are pointing down. And this is not unusual with ZFAN. You know, it's a stainless steel device, very rigid. When it fails, it also pulls down. So I knew this right renal, as you can see, is pointing down here. It's going to be a hassle. So what I advise people to do is cannulate them and balloon them, flare the metal so you can open up. But despite that, you can see there's almost like there's narrowing or a problem with that right renal. So I knew that's going to be a problem. So what I did is I pre-cannulated it with a wire ahead of advancing the fenestrated device. So I had the wire in it all the time, and I'm glad I did that. So with time, you anticipate which one is going to give you a problem, and that allows you to be ahead of the game. So you can see, I mean, the repair went well, but I just couldn't get into that right renal. You can see there's a lot of artifact, right? You already have a ZFAN, now you have a modified graft. I mean, those cases, when I get them, even though, I've done many successfully, but I always cringe when I get one of those cases because it's not easy to see. So what we finally did, I decided to utilize with the wire I have. I was able to get the outside fenestration, but not into the target vessel. So what we did is as you can see here, I passed the indie snare over the wire from the wire that I already had in the artery, in the renal artery. And then once I was able to get out with my wire through the fenestration, but not into the stent, then I snared that wire, and then I pushed the wire with that snare into the target vessel. Now, you can see it's aggressive procedure because you could easily dissect that renal artery. But then once you have that stable system, then you can advance the wire from your steerable sheath, and then don't lose it until you have your wire confirmed with angiogram, and then you can lose the system. And as you can see here, I have now the 035 all the way down, despite having the rail system. And then eventually I was able to send it. And I'll be honest with you, I was lucky. I did not dissect the renal artery. We were able to save it and give the patient a successful repair. Cone beam CT showed great result. And you can see this is the completion picture. This is the Indy snare. If people have not used it, I think it's underutilized. I love it. I always have few on the shelf in case I need to utilize it. So you keep your snare on the wire, you open it, you pass the wire like I did from the fenestration, you collapse it, and now you push the whole thing over the wire into your target vessel, and then at the same time, you're pulling your wire into the target vessel for successful revascularization. So this was the completion CTA, really great result, honestly, for the patient. And he, 2 weeks later, because this was done percutaneously, he was able to get chemotherapy, resume his chemotherapy for the lung cancer. And I believe he lived 12 or 14 months, unfortunately, after that intervention. So this is a patient that was actually done locally at Loyola with a fever, this patient came in also with a contained rupture, expanding aneurysm. Actually, sorry, this was an expanding aneurysm. She was not ruptured, but I believe with the expanding aneurysm, she experienced a lot of pain, and she had a significant type 1 endoleak. And honestly, looking at the images, this is not a good case for ZFN. Since this was done at my institution, previous institution, I was able to get the images. This patient should have had the 4 vessel fenestrations at the beginning. But again, as you can see here, the renal arteries, again, the device migrated, they're pointing down. I don't know if you can really see it, but both renal arteries are pointing down. Despite me flirting it, it didn't work. So what I decided to, because the left was pointing down very, very much, I decided to do an inner branch, and also the device was very small, so I didn't have much room. So for the left renal, I built an inner branch. This will be easier. I thought I can get in, look up on the. So basically, since it's facing down, I put my fenestration a little bit lower. So I'm literally looking at the pre-existing renal artery, and that allowed me to get in easily. But as you see here, despite me getting into the fenestration, I'm having a hard time pushing the catheter. And then I'm not sure if you appreciate the 2 dots here. I was able to sneak a balloon also through that fenestration, then inflate the balloon to stabilize the system that allowed me to then advance the catheter and switch to a stiffer system, which usually in those cases, it's a Rosen. But again, in order to do that, it's always if access allows you, put 20 sheath, 22, 24 French sheath, because then you can body wire multiple wires and allows you to do these adjunctive maneuvers for a successful recanalization. And actually, the same thing happened on the right side, surprisingly, again. But again, just to show you, those failed Z-fans, they're not easy. I also had to do the balloon trick. But again, this was the retrograde inner branch, good repair. But honestly, I'm not a big fan of them, but I have to do them. So despite the beautiful cone beam CT and completion angiogram, sorry, let me show you here. You can see a really good result. Unfortunately, this patient, well, sorry, I'm ahead of myself. So also we dissected, unfortunately, the iliac artery, but we saved it with a bare metal stent. But you can see, I mean, with the digital zoom and the fusion techniques, despite metal on metal, all these fenestrations, I mean, it's a reasonable amount of, I finished this case with only 1400 milligray, which is honestly, it's not bad for such a case. Patient came back, had excellent result. Duplex 6 months later was excellent. And then all of a sudden she came occluded, that inner branch and stent. We have no idea. I couldn't salvage it. And unfortunately, she lost her left kidney. But there's a lot of data telling you that, you know, those retrograde branches in the renals don't do well. And obviously, this is a proof that they don't do very well. But she also was smoking too. So this is a case, patient that had an ABF. He had endoside repair, and you can see the proximal anastomosis degenerated to 5 centimeter. He needed a valve repair, and they wanted this aneurysm fixed first. The problem here is, as you can see, you have short main body for the graft and endoside, and also this patient had, sorry, I didn't have the CAT scan to show you, but both external iliac artery were occluded, and his right internal iliac artery is filling antegrade. So I can't convert him to end-to-end without preserving pelvic flow. I really thought about this case a lot. So one issue is that I had to use a flex device, but I had to raise the device so I can open up the gate above the other side to cannulate it. That means I have to worry now about the SMA and both renals. So I decided in this case to do fenestrations for the SMA and the left renal, and then laser the right renal artery. But also I decided to put the posterior branch. So I sutured a 6mm Viabond, and then I here cinched it so it doesn't float, gives me some stability. And then the reason I put it posterior so that it opens up here in this area. So then it's open so I can get into the native vessels into the right hypo. And that's what we did. So also was not easy. I had to telescope a 6 sheath inside an 8 and to finally get a quick cross into the right internal iliac artery. And then as you can see here, then I built with Viabond and VBX, 2 stents, and this was the final picture. Really was very happy with this repair, and the patients did well and was discharged the very next day after this repair we were able to preserve pelvic flow. This is another interesting case. This is a patient with non-connective tissue disorder. I had all this repair done somewhere else. He had a TIVA with cardiac subclavian bypass. He had an ABF with implantation of the lower left renal, but now the visceral segment is completely degenerated. And he was sent to me from from Wisconsin to fix the rest of his aneurysm and dissection. You can see here, I put on the side, if you can see that everything comes off the true lumen, false lumen. And then, I always like to present a major complication just to show you, the complexity of the cases we do, and then what in my mind should be done in those cases. The repair honestly went really well. Here, what I did also, I went through the fenestration. I used a laser spectranetics to put a hole through the septum and go from the true lumen to the false lumen. And then I was able to select the left renal artery from the false lumen. Like I said, it went really well, was very happy. Everything looks great. Funny enough, the case which maybe I should have coiled this lower renal artery that they plugged into the ABF. It gave me a lot of hard time. You can see I dissected the artery, but I thought I fixed it with a Viabond. But then towards the end of the case, the anesthesiologist told me that the patient is very hypotensive. Sure enough, I take a picture and there's a perforation in the lower kidney. I fix it, coil it. And then the anesthesiologist tells me, well, he's still very, very hypotensive. I don't know what's going on. So then knowing his connective tissue disorder, I went and selected the left kidney and look at that angiogram. I mean, the parenchyma, the ruptured. You can see, I mean, this is a freely ruptured, and that's why he was hypotensive. Obviously, now we have a complete thoracoabdominal repair. I worry about spinal cord ischemia. So again, I like to present this case to show you sometimes you have to make a tough decision, and I coiled the whole kidney. And then to preserve, to correct the hypotension and the bleeding, and as well to prevent spinal cord ischemia from hypotension. I was lucky. I'm not proud to say that his creatinine was still normal, GFR 87. He had a good right kidney, but I wanted to show you things that you have to anticipate in some of these cases. Finally, no, I think I have a few more cases if we're doing okay with time. This is a patient that my partner did TVAR for malperfusion. And a few years later, you can see either he developed a CNE but the aneurysm was very large, and it was during COVID. I didn't want to wait and worry about losing the patient. So I thought, again, based on my previous PMAC experience and candy block, I was like, why not? I don't have access in the US to homemade candy, manufactured candy plug. So I decided to do my own. And you can see here on the stent, we're in the true lumen, and then the other stent, which is modified, is in the false lumen. You can see the wire barely goes further because of the false lumen. I like to use a dissection stent, which has 3 stents, and I like to cinch the middle stent with the Athabon to cinch it down. And then I decided to place the candy plug in this area. As you can see, there are two large fenestrations. I knew if I plug those, in addition to bring stent graft here, I will stop flow into the false lumen. And you can see this is the completion. But also, I was worried since I'm going to have a stent graft here in the false lumen, even though it's thrombosed. And you can see this is the Amplatz plug that I deployed in that cinched middle stent. Is that I've deployed the Cook bare metal stent to hopefully have some opposition and not compress the true lumen. But surprisingly, you know, again, you can see how much the true lumen opened up. And one thing I did is I ballooned, as you can see here, before I deployed the candy plug. I, you know, like not necessarily Knickerbocker technique, but I was a little bit aggressive by ballooning to open up the true lumen before I deployed the candy plug. And then I think that really helped open up the true lumen. And if someone's interested, we published this in Annals of Vascular Surgery. And really a 6-month follow-up, the aneurysm regressed by almost a centimeter with a cessation of the false lumen flow. So will I be doing a lot of those? I don't know. I mean, I'm hoping. I know I've done many of those PMACs. I'm happy just to walk in the room and have a graft on the shelf. So we do have TAMBI here. Actually, that failed snorkel. I think I'm going to tackle it with a TAMBI in 2 weeks. I heard T-branch might be coming to the US soon, so that's great news. We have options to use stuff off the shelf. A lot of people ask me about IDE. I think it's important. I did not I don't have one, mainly because of cost of the IDE and maintenance of the IDE. But honestly, I think anything outside off-the-shelf device, whether snorkel, chimney, laser fan, I think it needs an IDE. I personally have a problem where people criticize PMACs, but I think everything else we do also needs an IDE. And let's face it, I mean, especially in the US, a lot of patients do not want to travel. You know, a lot of patients ask me if I'm actually coming to the outer state where they're coming to see me, if I want to do the surgery there. And then when I first started doing them at Loyola, I looked at my first PMAC cases at Loyola when I was there before moving to Rush. Out of the first 50 I did, 44 were referred by other vascular or cardiac surgeons. So obviously, in these cases, they were not comfortable doing, or whether endo or open. 2 refused surgery. One of them I actually treated because his dad died during an open elective repair. And he was a candidate for open, but he didn't want open. And we did endo. And then the other patients had like either abdominal surgery or history of cancer that we performed endovascular repair. So in conclusion, you know, I think at the end of the day, what I tell my trainees is that they need to do what they're comfortable doing. I shared with you a story. I had a vascular surgeon in the US call me to, he wants to learn PMAC over the phone. I hang up the phone and I told him before that not to call me again, because obviously the physician doesn't know what he's getting himself into by just doing this on the fly. I visited other surgeons before I actually started doing physician modifieds myself. I practiced in my office. And like I said, I really switched back from, I tried snorkels and chimney. I didn't like it. And then I like PMAC because I really can tailor the graft to the patient's anatomy. My advice is start with straightforward cases, you know, iliac branch device, 1 fenestration, maybe 2, and then move on to the more complex cases. I think you have to be honest with yourself and you have to look at your results and examine them and make sure you are providing good care for the patients. Planning, you know, is key for those cases. Like that case I showed you with a patient with a ABF with antoside and the pelvic to figure out how I'm going to fix his pelvic perfusion without doing open surgery. I looked at it so many times, so many hours, and then finally the posterior branch clicked. I was happy with that. And then, so just to show you, those cases take a lot of planning and troubleshooting. You know, I think with evolving technology, I don't think we're going to have to do PMAC and snorkels. I think snorkels are good for emergencies, but I personally, I switched to laser fan in emergency. Happy to also talk to some of you guys about my protocol if someone comes a rupture with a laser fan. But I think that's the way to go, honestly, for ruptured aneurysms. You know, publishing is important. As you can see, the reason I included those is just if we have junior faculty or trainees on the program, I really think you should publish. This way you get your name out, people invite you to speak, and then you build your reputation. Thank you very much for this honor. Really, this society is dear to my heart. And again, I want to thank Dr. Habballah and the committee for the invitation. I can't hear you, Dr. Habballah.
Well, I applauded while the micro was muted, but thank you very much for a very informative presentation and showing us how to tackle a very complex situation. So I'm gonna start by asking our panel to make some comments on what they would do, how would they their thoughts, and then I will take questions from the audience. Let me ask Dr. Sharafuddin, could you share with us your experience and what would you do differently on what has been presented? And I will ask the same question to Dr. Rafat Jabir.
I mean, honestly, there's very little you could ask after such an amazing presentation. Bravo, Carlos.
Thank you.
I do share a lot of your perceptions and attitudes toward it. One thing I was wondering about, it's obvious that you prefer the Cook platform, your modified devices. And in my case, I seem to have, I don't know if I should use the word evolved, but I have an affinity to using Terumo products. In fact, my IDE, my FDA IDE is based, the premise of it is the use of Terumo devices. What are your thoughts about the role of various devices in certain cases?
Yeah, great question, Mel. First, let me tell you, when I shifted from TX2 to Alpha, I mean, it's amazing. After done so many cases, there was a learning curve. I mean, when you switch from one device, you get so comfortable modifying a device, and you move to another one. Honestly, there's that comfort and few cases where you have to do to really know the device before you can modify it and feel comfortable. So there's that factor for me switching again to another device. Now I have modified arch cases with the Terumo device, but I agree with you. I think the bifurcated device, especially for cases with short main body or ovation or like previous surgical graft, I think having bifurcated graft is fantastic. I have to admit Terumo is a great choice because you have a long main body. It allows you to put the fenestrations freely everywhere. And finally, one thing that a video was shown to me that if you rotate the device, it's not going to deploy or malfunction. I mean, the top cap is so attached that you have to release it at the end. So that really allows you to move the device and not worrying about dislodging it or starting to open it, which could happen with the Alpha. No, I think Trio is a great choice, and for people who are comfortable with it, I think it's a great one to use for physician modified endograft, 100%.
Yeah, I agree about the stability of the platform, the ability to rotate, but I would never do what I'm sure they showed you, the Ben Starnes fringy technique, but I never do that. Instead, I rely on aggressive diameter reduction. Like you, I prefer to use circumferential now with Chromic. I think the level of comfort increases as you become more familiar with it. One quick question, Carlos, on mitigation of paraplegia. What are your thoughts about vent fenestration or even placing a bare metal stent as a temporary measures, and later you come back and cover it with a fabric covered stent?
Yeah, actually, I should have included a few cases. Hopefully we should have. We just submitted revisions to JVS where I had several cases. with changes, intraoperative changes. Let me back. So patients that have access issues that I don't want to stage it, do a TVAR and come back for the PMAG, I do it in one stage. Small. If I'm doing conduit, endoconduit, open conduit, I just like to get into those iliacs one time, finish the repair. If there's changes in the neuro monitoring, then I actually leave the celiac unstented, and because it's closer to the chest and RGF Adamikowitz, and then I bring them back 6 to 8 weeks later when they're awake, go through the arm, and then I do a test occlusion balloon and ask them to bend their knees and hips, and then if that's okay, then I proceed by stenting it. So similar to what you're saying, and we've had great result with that technique, and then should be hopefully once the revisions get accepted, will be published in JVS.
Very nice. Great presentation. Congratulations, Carlos.
Thank you. Thank you.
Dr. Rafat.
Yeah. First of all, congratulations. Excellent presentations. Very complex cases. I have to go to the Terumo. I like the Terumo because actually the distance between the struts is bigger than with Cook, so you don't have to modify the wires and or the struts. Sometimes what you have to do in Cook. Unfortunately, in the US, we still have limited access to patients' custom-made manufactured devices. Even though we use TAMPI in our practice, 50% of patients are not candidates for TAMPI, so you have to do something else like modified grafts and things like that. So I think Cook is a good device. Terumo is good. Terumo for us is probably better to use just because more struts. In terms of the spinal cord, I don't know. There's a clear evidence. The stage in these procedures sometimes it's less spinal ischemia. So we do the TVAR and then come back. Sometimes we do the perivisceral segment and just come back again and do, unless you have a really bad access. And what I've done for the bad access, we do conduit. I just do conduit and then I bury it in the sub-Q. So and that way, if you have to come back, you just expose it. Like you do a iliofem bypass and then you cut down on that bypass and you access again, so you don't have to do conduit again. So that's what we've done. But I think it's excellent presentation, excellent things. And my question is to you is like, what is the rates of re-intervention on these patients that you have? Normally it's about 30% in manufactured devices. In these modified grafts, what's your rates of interventions on these re-interventions?
Yeah, so I looked at it, the data before leaving Loyola. Luckily, I've had no SMA re-intervention. I only had one for endoleak, like no stenosis for 1C endoleak that I extended SMA. But I've had few celiac artery occlusion, which correlates with the literature and the compression with the almost like a Mal's picture, and that led to occlusion of the celiac artery. They were completely asymptomatic. But I've had renal was around 3 or 4% risk of renal intervention for occlusion and for stenosis. So renals are the main target vessels that unfortunately, we still have problems with whether you do PMAG or other off-the-shelf devices.
Yeah, go ahead.
Yeah, no, I'm just saying those renals are always a problem. Yeah.
Yeah, they are problems, but do you use VBX or you use like I don't see ICAS anymore. We exclusively use VBX now. VBX.
Yeah. So VBX. So the only issue with VBX is, as you know, the struts are individual, so there's a gap between the stents. So some people worry if the distance from the fenestration to the target vessel, some people say 5 millimeters, some people say 10 millimeter. And as you know, the renal arteries are very mobile with respiration. So some people worry about fatigue over time. So I personally, if there's more than a centimeter to the target vessel, then I might build an outer branch to allow me to get closer to that target vessel. And then I usually use VBX. And if I'm worried about stability, then I'll extend with the bare metal stent distally to really anchor the stent so it doesn't move and slip out.
Sure.
Great.
In dissection. Yeah, go ahead, doctor. So
No, I just have some very interesting questions from the audience, so I thought it would be important to try to share them. So I'm gonna read all the questions, and then we'll go back and then take one at a time. So one question is, how would you describe the learning curve? How many cases would you recommend in vitro before embarking on such thing? Because actually, one of the purpose of showing this or doing this webinar today was so that our colleagues in the region here, if they want to get involved in doing any of these devices, will be able to get some thoughts and maybe figure out how to be prepared for it. So that is one question. The other question relates to bridging stents. Which stents would you use and how you preload the wire in the fenestration? Another question on using Medtronic prosthesis. And finally, there's a question on the 3D printing technique and whether you have considered printing and sterilizing the 3D templates to help with what you are building. So these are some of the questions that were asked. So let's start first with the learning curve. What do you say about the learning curve?
So, I mean, luckily we are training more and more people. Like I can tell a lot of my trainees now left and built a PMAC program. So, that's that. I think having an experience, having two surgeons do those cases is very helpful, where you kind of talk about it and help each other out. And having someone who had some experience with it is great. Now, if you don't, I really advise visiting someone just to see how they do it, take notes, and see how they modify the graft and do it. And then when you go back, just choose wisely. Choose a case which is easy, like I showed, like iliac branch device, and maybe 1 or 2 fenestrations. But I think you need to do at least 10 to 20 a year to keep that level of comfort and experience. So if you don't have that volume, the question is it worth it? To start that program, I don't know. I mean, obviously, unfortunately, we live in the US where profit is important and RVU. But I think you really need to do at least 10 to 20 a year to maintain those skills. Yeah.
What's your favorite bridging stent?
So I've had good results with VBX. You know, and the reason for that is the old ICAS, for those who use it, it was very unstable. You know, the balloon mounting was not very stable. We've had some ICAS fly and get dislodged. But now the new one, I have to say, is much better. For those of us who are in some clinical trials, now we have in the US Bentley, the graft for clinical device for clinical trials. My only caution for Bentley is it's like AFX, the metal is on the inside. So be careful when you come back for reintervention on the renal, especially that you're not inside those endoskeleton. But I think it's a very good stent. But I personally have had good results with VBX.
So how do you preload the wire in the fenestration? You said a lot of times you go in and you used to pre-cannulate and this and that. And it kind of was not, for someone who doesn't do it routinely, is not very intuitive. So can you clarify?
Yeah. So once you deploy the graft on the back table and you have the fenestrations, you bring a catheter, KMP or burn or glide catheter, and you put it from the outside the graft into the fenestration, inside the graft, and then outside the tip. Now the tip of the graft, the proximal graft, should have no bare metal, because if you see the alpha, they're linked like this. So it's hard for you to make sure that your wire, it has to be through the start. So when you open it, it's going to trap your wire against the wall. So make sure you choose a device that does not have suprarenal metal, supra graft metal, I guess, or proximal bare metal stent, the right wording. And then you can pass. So you put the stiff end of the wire through the catheter, and then you feed it into the delivery system. It can go in maybe 20, 30 centimeters, depending on the delivery system, and basically just shove it into the delivery system. And then as you going in with the devices, you can snare that wire. So you can pass them through the sheath from the groin, snare the wire from the arm, And then basically you can label them too, if you know which one is which, and you can label them so you know this is renal, SMA, celiac artery, but you need two people. So as you're advancing the device, you want the person in the arm make sure that they're also coming back with a wire so you don't lose it, and then they're talking to each other so you don't lose those wires. So it should be like one gentle motion coming up, and then it's nice because you pre-cannulated. So then over that wire, you pass your sheath, you go outside the fenestration, you keep the through and through wire, your body, you wire, and you get into your target vessel. Once you get into your target vessel and you're secured with a stiff wire, rosin, or I love magic torque, but I don't have that anymore. I love that in renal arteries. And then you can lose your through and through wire and advance your sheath into the target vessel.
Any experience with the Medtronic prosthesis?
So I know some have. I've only modified one, and I can't remember why. This was a while back. Maybe I wanted to see how it works. It's not. I mean, it's not easy to resheath, but I don't have a lot of experience to really comment on it, honestly.
Okay. And a question from our dear friend Sharif Al-Lawzi. Have you considered the printing and sterilization, sterilizing the 3D templates and for the 3D printing?
Yeah, thank you, Sharif, and thanks for for everyone being on the webinar. So that's a great question. I know some people I've seen basically two things you can do. You can sterilize the paper where you put your fenestrations mark on it, and you can just wrap it on around the graft, or a transparent sheet, I should say. And then this way, so sometimes when you're putting the marks, I know Dr. Jaber mentioned the struts. So sometimes the cook struts might come in the way. So instead of like marking and confusing yourself, you can put the pre-printed sterile in the graft and decide where you're going to put your holes. You can rotate it, say, okay, this is good, this is not good, this is on the metal. So I think it's a great idea. I haven't done it, but what I've done is I have a sheet that on Word document that I can plot on it my fenestrations. I know where they're going to be ahead of time. But I think what he mentioned is a great idea.
Great. I have with me here, sorry. I have with me here as a panelist, Dr. Ma'moon Bashir. So I'm gonna ask his thoughts on it and its application in Amman, if anyone is doing it, and I'm
Thank you, Carlos. That's a great talk, and we're very impressed always with this amazing work. Maybe Jamal, if you mute your, yeah. Sorry, we're in the same office, and Jamal has been kind enough to give us his internet access and two computers in one room. But I had a question regarding the infection rate, and if you faced any, because one of the issues with the physician modified grafts is getting them out of the device and putting them back in, and that's obviously an increased risk for graft infection. We're in the region, we're not doing any of these, but it will be definitely a great asset, to be honest, because of the cost issue, because they're definitely much cheaper than having the fenestrated grafts or branched grafts, which we've done a couple of those. And it'll be nice to know if that's something feasible and if the infection rate is at all significant.
Thank you for that question, Ma'moon. I personally, I haven't, unless patient went somewhere else, but I've had very good follow-up, either with me or the referring physician send me how the patients are doing, especially those coming from far, so you don't have to come all the way to Chicago. I haven't had personally myself an infection. Actually, funny enough, you mentioned this because 2 days ago, one of my trainees who was here in Chicago did one, and then a month later, a patient came back and there's air all over the graft. But that patient is on steroids for rheumatoid or something. But I think also there was some issue with like transient ischemic colitis too. So I think like any procedure we do, the risk could be related to something else, not necessarily opening the device and subjecting the graft to infection. But again, you have to be very sterile. Obviously, we only do it in the operating room. We're very careful where we put the graft. I do it myself, or I train one of my partners to do it. So I'm always there, careful, make sure that we not have cross-contamination. I think if you limit the amount of people coming in and out the room is very important. But so far, luckily, I haven't had any graft infection. But it's a disaster. I had few referred to me. They don't do well. I've done a few with the cardiac surgeons, and as you can imagine, they don't do well, unfortunately.
Great. Well,
So
a lot of lessons learned here.
regarding infections, Carlos,
Yes, go ahead.
I would mention to the audience the importance of making sure the setup of the back table is robust enough, because we do a lot of manipulations. And I remember a case where the tech only did one layer on the table, and after we were done with the procedure, it actually implanted the device. We discovered that there was breach. Of course, if we freaked out and had to give him antibiotics, luckily he was he's still doing okay. But
Good.
be sure you have a multiple layer cover on your back table.
Excellent point.
Do you always have to take the whole device out? Like we usually take portion of the device and keep it inside, and we do the fenestrations and then put it back in. So not always I take it out. So unless you're doing branch, you know, if you're sewing branch, I take it out. But fenestration, I don't take the whole device out.
Yeah.
It just
Yeah, so that no, I don't. I agree with you. The only time I take it out completely, in addition to what you mentioned, if for some reason, so basically, one thing I didn't mention is I also mark where the aneurysm starts. So if I have a stent or two below my fenestration before the aneurysm starts, I usually like to cinch those two stents so that at least all the stents in a normal vessel are tight, so I can really move the device. And then I just leave, and then the segment that's going to be open aneurysm, I leave it because it's going to open. It can move the aneurysm. I don't cinch or constrain those stents that are going to open up in the aneurysm.
Great. Well, so lessons learned. I think what I learned myself, since I have never seen it done personally, is I need to visit Carlos or Mel or someone, or Rafat, someone who does them. I think it's important to kind of see someone who has done them well and learn, and rather than to just try to use it on your back table alone. And the second thing is, again, if you have the ability to have someone who has done them with you to double team it, I think that's very important. The issue of proper selection and not starting with the easier case first is also very important. You mentioned the cone bone CT. How do all of you have that tool available to you in your offices, in your hybrid rooms? Yes. So I think one has to realize that embarking on such a part of your such part of procedures is going to require some capital investment, and you need to have your hospital supportive of it and all that. The last thing is that maybe in the future some newer pre-made grafts that are going to be off the shelf that can help us in dealing with those without having to personally modify them. But I think, again, as you mentioned, Carlos, that in ruptured aneurysms, some laser modification and intervention may help us get out of trouble in some cases. So I think there are a lot of important messages that we learned here today. I just want to thank you all. Anyone has any questions that you would like to ask as the last? We're already. I think this was a great presentation. Any last questions? Mel, Rafat, Mahmoud. Well, again, I want to also thank the participants, Dr. Tanya Guzman from the Emirates, Dr. Ala Muhammad, Dr. Ahmed Sayed, Dr. Sharif Al-Lawzi, for all your contributions to the discussion. This was a special topic. I think we did not have this presentation is going to be taped and available for others to watch at a later time for those who could not attend today. But again, thank you, Carlos, for a great presentation and being supportive of PAVSS all the time. Thank you, Rafat. Thank you, Mel. Thank you, Mahmoud, everyone. And you all have a great day. Thank you.
Thank you.
Excellent.
Bye-bye. And thank you, Dr. Sherbini, for organizing everything here. I forgot to thank Ultimate Medical for the great job in getting these webinars on time and with all the process. Have a great day, everyone.
Thank you.